This is a super steep cornea, keratoconus. The central K readings are in the range of 80. That's not a misstatement. That's 80 diopters. So in a moment here, what we're going to do is tilt the microscope, take a look at it from the side as best we can. There we go. So you can see how steep that cornea really is. That's a real keratoconus. Okay, so now we'll just tilt the microscope back and proceed. So we're actually going to put an IOL in this patient, which he's about a minus 25 with 11 diopters of cylinder and is a very successful hard contact lens candidate. Irrigator. So he's going to stay a hopefully successful hard contact lens. He's not only a candidate but wearer. He's been doing it and he likes it. So he doesn't want a lamellar corneal transplant to flatten his cornea. So we're going to keep him. We're going to put an implant in that should he ever have a corneal transplant, he would then be approximately emmetropic. But in the meantime, he's going to remain a minus 20-ish, wear his hard contact lens, and go on. The only difference is he won't have a cataract to look through. So that's a bit different kind of procedure than one would usually think. Taking a minus 25 myope and leaving him there because he's a successful keratoconus hard contact lens wearer, and leaving him with his 11 diopters or so of cylinder, because that's his refraction, minus 20, minus 11. Okay, so we're staining his capsule because looking through the cone could be a little tricky from time to time. So it'd be nice if the rexus is really very visible. And now we're injecting viscoat. So we may wind up putting OVD on the surface of the cornea to try and get a better view if we need it. We'll see. So I'm now going, you can see the distortions through the cone. I'm opening the anterior capsule. So you can see, I mean, you can pretty much see the outline of the cone even, and there's some distortion to our view. So let's see what happens if we put an OVD, specifically an OVD ocucoat, on the surface of the eye. Capsular rexus spatula. My opinion thus far is that helps a good deal, that I've got much less distortion. Absolutely less. Now, why is that? What does the ocucoat do? Well, it has an excellent air OVD interface, and it also fills in hills and valleys. I mean, this rexus, I see just as well doing this, really, as if he didn't have a cone. Now, let's do something. Give me an irrigator. Let's just rinse off the ocucoat while we look. You see the distortions in the center there? As we get out to the periphery, but see how that center, you just can't quite get details? That's where we're going to be sculpting in a minute. Let's put some more ocucoat back on. To me, from my view, there's no comparison. I really see much better with the ocucoat on there. Okay, so let's now proceed to the viscodissection. Hydrodissection. This is a 23 gauge cannula. You see the nucleus is loose. Now viscodissection. Now, we may have to add ocucoat during the phaco. But if we do, so what? We'll just add some. The patient is 62 years old. There may or may not be, there's not much nuclear density here, I know that. So we may be able to do, yeah, it's quite soft. Look at that. I think we'll aspirate the whole lens. Let's go to quadrant. There's enough density to rotate it. As you can see. But I don't think there's enough density to have to use ultrasound. But we'll find out when we get to the deeper nuclear layers here. Yeah, that very dense central nucleus, or rather denser posterior central nucleus. That will probably need some ultrasound. Okay, so let's put some more ocucoat on right now before I go down deeper. Inject the ocucoat on the cornea. Good. Sculpt. You can see the really good view that I'm getting of the deeper nuclear layers. This is a super deep chamber. And then I'm going to even put some more ocucoat on right now. And you just wait several seconds after you put the ocucoat on for the view to get as clear as possible. Now I can tell you this is at the limit of the microscope's ability to give you clarity. What would you do if you couldn't? I mean, literally, couldn't see clearly. That deep. What you do is go through the pars plana and give an injection of either BSS or an OVD and shallow the chamber. And I've had to do that, I'm going to say 5 or 10 times in my career with ridiculously severe long eyes, axial lengths 35 or so. Okay, quadrant removal. So dividing this nucleus pretty well here. And now let's put some more ocucoat right on. Good, and then we'll wait. And there's our good view. Now you can use an OVD and ocucoat's really the best one that I found for this. You can use the OVD ocucoat, not just in eyes like keratoconus, but any anatomic abnormality, dryness. It's a good one to use in those. You'll get a better view if you've gotten some SPK in the cornea for whatever reason. But think of it whenever you have some corneal impediment to vision, to visualization. Okay, so there's our phaco. So here's our 90-degree INA tip. And again, I'm going to put some more ocucoat right on the cornea now, or have my technician do it. Good. Wait a few seconds, get my best view. So working through an 80 diopter cone. You may not often have the pleasure of doing it, but you will have some irregular corneas for many reasons. Okay, Provisc. a little opacification or lens fiber material right there. Going to rub it off. And just filling the capsular sac there with the Provisc. The IOL we're injecting here it's about a 13 diopter IOL. But as I said at the beginning, he'll still be a high myope wearing a contact lens until such time as he can't. And if and when that happens and he gets a graft with a K reading of about 44, he'll be approximately an emmetrope. You see, even if we put in an IOL that made him emmetropic, it might be a -5 or whatever, he'd still have to wear a hard contact lens. He couldn't see because of his corneal abnormalities. So there's just no reason to do it. All right, so IOL in position. I'm going to rotate it just a little bit so it's horizontal. Good. Center it up a little here in a second. It's a big capsular sac. Super deep chamber. I mean, I have to reach way down to get to the IOL. Syringe. Look straight at the light. Good. So now we'll just do some stromal hydration. What an effective lens position this is. I would guesstimate an ELP here of perhaps 8 millimeters. It'll be interesting to measure it post-operatively and see what it actually is. But it's enormous. Syringe BSS. So just like in every other patient, we want to irrigate the OVD out of the angle. Reduce our chances of a pressure spike. And last, we'll put some vancomycin in this eye. And I'm going to do a little more stromal hydration because I think there's probably still a little fluid coming out of that side port. We can see that. But I saw a little fluid still coming out there. Yeah. So in cones, that's sealed. In cones, you know, their peripheral cornea can be pretty thin, and it may not close as readily. So, you know, you can be sometimes a little blasé with these side ports and say, oh yeah, that's going to stop. And they do. But in thin corneas, let's just be a little more cautious and make sure that they really do stop. IOP is being well maintained. That doesn't mean there might not be a minimal amount of little flow there. Yeah, just a little tiny drop or so coming out. Call that a minimal little ooze. And those are the kind of things you'll see all the time with side ports. And you can wait for a minute or two and make sure. And now, in most patients, I just say, okay, up and out. In a cone with potentially thin cornea there, what I'm going to do is I'm going to turn off the lights. You can see that it's almost stopping right now. And in a minute or two, we'll look one more time. So here we are. We're now about a minute and a half, and you can see that that side port incision is now nice and dry. Everything's just fine. Good.